I like you to thank you on behalf of the Sri Lanka College of Cardiologists. But in view of time, we have to move on to our next speaker, who will be Dr. Sandeep Kalra. He is a consultant cardiologist with a special interest in interventional cardiology and works at the Royal Free Hospital Trust. He will be talking to us on how to optimize stent deployment in a calcified lesion. So over to you, Dr. Sandeep.
Thank you very much. If you just bear with me whilst I share my slides. Fine. So thank you very much to the Sri Lanka College of Cardiology for this invitation to talk. And I was asked to speak about how to optimize stent deployment in a calcified lesion. So I'm going to try and keep this as clinically focused as I can and use a couple of cases in the box to describe how I would approach optimizing stent deployment in a calcified lesion. So we'll just start by showing what I feel we shouldn't be doing when we're treating calcified lesions. And I just want to give an example of a case done in my center by one of my colleagues, and I just want to show where we can have pitfalls, and then how I would use a very simple workflow to try and avoid these types of pitfalls. This is a patient that presented to one of my colleagues. He was 85 years old, presented with an acute coronary syndrome with ECG changes in his LAD territory. As we can see from the angiogram here, there is severe diffuse calcified disease in the mid-LA, approximate to mid-LAD. There's also a CT of the right coronary artery. Based on the ECG changes, my colleague went about trying to treat the LAD artery as a culprit vessel here. You can just see in the top left panel there, a stent is being deployed in the mid-LAD first after pre-dilatation. And in the top right panel, we can see a second overlapping stent is being deployed. And this is just at the site of where we saw the most angiographic severe stenosis. The third panel, we can see when the second stent's deployed, there is dog boning of the stent. It's incompletely expanded. That's a non-compliant balloon, and they're trying to post-dilate it. And we can see the final result is, despite high-pressure non-compliant balloon inflation, there's incomplete expansion of the proximal stent. And this is how the case was left. This was not treated any further. I will come back to this at the end, but this is just what I would say is how I would try and avoid treating heavily calcified arteries. So if I had to answer how to optimize stent deployment in a calcified lesion, there's a few things that I would consider. Firstly, I think we need to understand what the challenges are of treating calcified lesions with PCI. We also need to understand the tools available to us in 2021 to deliver optimized procedures. And we need to understand the interaction between these two areas. So we understand the challenges and understand the tools, we should be able to deliver an optimized procedure. So if we just speak a little bit about the challenges first, the rate of procedural complications is undoubtedly higher in vessels that have moderate plus calcification in them. There's an increased safety risk in these types of procedures. There's greater procedural complications, including major dissections and coronary artery perforation. Heavy calcification impedes stent delivery, and not just stents, but also delivering other kit in there, such as balloon therapy, to try and predilate the vessel. But particularly with stents, severe calcium is an independent predictor of not being able to deploy a drug-eluting stent. And we know that this can damage the metal scaffold as we try and get a device through the calcified area. It can also damage the polymer and also damage the drug coating as well. As I demonstrated in the first case just now, there is the risk of stent underexpansion in calcified vessels, particularly if they are underprepared. Calcium severity is well correlated to the increased risk of stent expansion, and that's associated with downstream cardiac events. We know that the greater the arc of calcium, the greater the length of calcified disease, or the greater depth of calcium, the greater the likelihood of stent underexpansion. The long-term outcome is also worse in arteries with undergoing PCI that are heavily calcified. We know this from various studies looking at various parameters, but essentially there's increased mortality and increased cardiac events in patients that have PCI undertaken in calcified vessels. There is special consideration for certain subsets of anatomy, so particularly with bifurcations, left main stem, and CTOs, the approach to delivering optimized results in calcified vessels. And these anatomical subsets are different, but not what I'm going to focus on today. And then also we must be able to distinguish the difference between medial and interval calcification. Pathophysiologically, they are very different occurrences, and also how we treat them is extremely different as well. It is no longer acceptable just to say that you have a calcified vessel. We need to define whether this is interval or medial calcium, and we will choose our tools appropriately according to where the calcium is. So if we talk about the tools available to us in 2021 for treating calcified vessels with PCI, I think it'd be an oversimplification just to talk about rotational atherectomy and shockwave. These are the vogue tools that we'll talk about now, the RotaPro from Boston Scientific and Shockwave, the Shockwave balloon from Shockwave Medical. And this is what we could end up talking a lot about, but this would be a gross oversimplification and not the only things that we have available to us to be able to treat and optimize results in calcified vessels. But equally, we can overcomplicate things, and there are various algorithms now in the published press about how to treat calcified vessels. This is an algorithm that's had quite a bit of traction in recent times, talking about the options available to us and a workflow of how to treat calcified vessels. As a personal opinion, I think this is overcomplicated, and I don't think every single vessel subset or every single anatomical subset will fall directly into this. It's important to have a workflow, but also important to be able to adapt according to the individual case. So if we just come back to the tools currently available to us, I'm just going to concentrate on the right-hand side first, and what we would normally reach for are some of the balloon-based techniques. So beyond a semi-compliant and a non-compliant balloon, we have cutting balloons, scoring balloons, high-pressure balloons, and now lithoplasty balloons available to us. There are ablation techniques, so we have rotational atherectomy, we have orbital atherectomy, something that in the UK we do not use at all, so it's something I have almost zero experience with. And then also we have laser therapy as well to try and treat calcified vessels, and these are the options currently available to us. But key to this, beyond just having these tools to treat calcified vessels, intravascular imaging is absolutely key, and I'll demonstrate now in a few cases how we can use intravascular imaging to choose our tools, but also to help us deliver the best procedure we can. So I showed a few slides ago an algorithm to try and overcome the challenges with coronary calcium and treating these vessels with PCI. Now, from the USA, Sky have issued their workflow for trying to treat calcified vessels, and I think this is a lot easier to follow. Now, this is essentially formalized what a lot of people have been doing procedurally, but this is a very simplistic workflow, and I think it works well. So the first thing they said, the entry to thinking about using slightly more advanced tools for modified calcium before you deploy a stent, or if you identify on fluoroscopy that you've got moderate to severe coronary calcium, so if you're essentially seeing tram lines on your angiographic images, or if you get inadequate balloon expansion during lesion preparation. I would add a third point to that. A lot of my elective patients arrive on my cath lab list following assessment with a CT coronary angiogram. And if I know that a patient is going to has got a high calcium score on their CT coronary angiogram, they are another subset of patients that I would automatically use intravascular imaging before making any decisions on how to treat the vessel. So by any of these criteria, if we've identified that there's fluoroscopic calcium, inadequate balloon expansion, or in my case, I've added in there a high calcium score on CT, we should proceed to intravascular imaging first so that we understand what we're dealing with, we understand which tools we need to use, and we understand what devices and what size devices we're going to use. Now, there are a subset of cases where you'll have uncrossable lesions, so you're unable to advance an imaging catheter through the vessel despite predilatation. And in that situation, then you are going to be looking at using atherectomy as an initial first step so that then you can image the artery and decide what further tools you need to use. But if you are able to successfully undertake intravascular imaging, then you really need to make a case-based decision on what you're going to do next. Are you going to try and use balloon therapy to try and expand the vessel? Are you going to try and use mechanical atherectomy? Are you going to be using lithoplasty balloons? And then absolutely key is that once you've decided what you're going to do, once you've prepared the lesion, once you've deployed the stent, you need to image again to make sure you understand has the stent been fully expanded, which is one of the key risks of trying to treat calcified vessels. So I think this is best highlighted if I can demonstrate a couple of recent cases that I undertook. So the first patient is a 69-year-old patient, only risk factor of cardiac disease is hypertension. He had a very good history of limiting stable angina for 3 months, despite being on 2 anti-anginal agents. Now, the angiogram is not terribly exciting here. It's not something that I immediately thought I would proceed to PCI with. So we can see that there's a moderate mid-LAD stenosis just after the departure of the first diagonal. There is disease in the ostium and proximal course of that first diagonal branch, and also there's a severe ostial stenosis of a large first septal branch. So on immediate angiographic appearance, I was not considering that this would be something that would require PCI, but as we've so eloquently heard from Dr. Davis just now, physiology is really the key to help guide us on what to do in this situation, especially in the elective situation. Now, I undertook pressure wire assessment. So the LAD had an FFR of 0.76. The diagonal had a FFR of 0.84. So I'd made my decision for this patient to undertake PCI. He was on already reasonable medical therapy and still getting significant symptoms. So I went on to undertake an OCT evaluation because on an angiographic appearance, I wanted to identify where my landing zones were, but also I felt that there was some calcium in the LAD artery. Now, what I'm displaying up here is the Ultron OCT system from Albert Vascular. I had early access to this back in May 2016 and was fortunate enough to be able to use this back then. And I now have about 100 cases of OCT, Ultron OCT optimized PCI. Now, as we can see, part of the algorithm for this Ultron software is calcium detection. So you will see on the axial views here, in the circumference, we are displaying orange lines where there is more than a 60-degree arc of calcium. We can adjust that to wherever we want to, but in this case, if there's more than a 60-degree arc of calcium, it's telling me and identifying that on the clock face with the circumference highlighted in orange. Also, on the co-registered view, we can see that they've drawn tram lines in orange where there is calcium present. And that wasn't entirely identified from the angiographic appearances. I'm just going to forward through and just go onto a frame where we see the most severe stenosis in the LAD artery. So we can see that there's a 310-degree arc of calcium, and it's almost a 1 millimeter depth at most. So we're not talking just about intimal calcification. There is medial calcification here as well. I also imaged the diagonal vessel. Although it had a negative FFR, there was a consideration here that there's a considerable amount of plaque when I did the OCT of the LAD, and there'd be concern about plaque shift into the diagonal, but also I wanted to anatomically assess the diagonal vessel as well. And as we can see, we're going from proximal to distal. As we are going through the diagonal vessel, there is calcium in the ostium of the diagonal, calcium in the proximal diagonal vessel. And my consideration after assessing this was that if I was to treat provisionally across there, which was my initial preferred technique, after doing OCT off the diagonal vessel, this would be always a much more difficult case to rescue if you needed to balloon back into the diagonal or to do a kissing balloon inflation at the end if you were just using a provisional strategy. And again, just on a still axial image here, this is just proximal diagonal vessel at 217-degree arc of calcium with a 0.84 millimeter depth. So again, we're not dealing with just intimal calcium here. There is also medial calcification. The software also allows you to plan your stent length, so you can assess the lesion. We can see 3 panels here. On the left is where I set my proximal panel. We can see the dotted line for automatic EEL detection, so you're stenting to vessel size rather than just lumen. The panel on the right shows the distal reference that I've marked. I've got a 28 millimeter length lesion marked out here, and where we can see my marker in the middle is just the middle panel there. Now, we haven't got enough EEL, so we haven't got more than 180 degrees of EEL to be able to detect an EEL length. So all we have is the lumen size here, but we can make, and this is in the diagonal as well, we can see in the diagonal there is 180 degree of EEL detection. So distally, where I would think about landing a stent, although the lumen size is only 2.15 millimeter diameter, the EEL is a 3 millimeter vessel. So based on these OCT findings, there's concentric deep wall calcification in the LAD, including the bifurcation. It's diffusely atheromatous, a 28 millimeter stenosis length. The distal LAD size that I marked was 3 millimeters diameter, and the proximal was 3.5 millimeters. The first diagonal had deep wall calcification, 11.3 millimeter stenosis length, and the distal diagonal had a 3 millimeter diameter. So the plan was to treat the LAD and diagonal with shockwave therapy here, and the reason I was treating the diagonal, even though it was FFR negative here, is due to the anatomy identified, the calcified anatomy identified on the OCT. Based on the vessel sizes, I chose my technique as a DK crush here. I just again, with the volume of plaque around the first septal branch, I treated the first septal with POBA before starting to deploy any stents. The LAD I treated with a 3 millimeter shockwave balloon, deploying 40 pulses and then expanding with a 3.0 millimeter non-compliant balloon, and got good angiographic expansion in this area. The first diagonal, again, treated with a 2.5 millimeter shockwave balloon at 30 pulses, and pre-dilated with a 2.5 millimeter non-compliant balloon, and again, achieving good angiographic expansion here. So standard DK crush technique, a 2.5 millimeters by 16 millimeter synergy drug-eluting stent in the first diagonal, a first kiss, a second stent in the LAD, a 3.0 by 32 millimeter synergy drug-eluting stent, proximal optimization of the LAD stent with a 3.5 millimeter non-compliant balloon, a second kiss, and then a final pot of the LAD with a 3.5 millimeter non-compliant balloon. And this is the final angiographic result here. An FFR at the end of the procedure showed in the LAD it was 0.86. On OCT interrogation, using the Illumian 3 criteria, there was 92% stent expansion in the LAD and 89% in the first diagonal. So both angiographically, physiologically, and on intravascular imaging, a very acceptable result here. Now, this is absolutely key to... Oh, sorry, my slides have... Sorry, apologies, my slides are... I think my slides have stopped sharing. If you just let me... Bear with me 1 second, I'll just put them back up. Bear with me, sorry about that. I'm not sure what happened then.
3 minutes තියෙනවා හැබැයි auto lock වෙනවා වෙන්නේ නැති.
Okay, can I just double check we can see my slides again before I carry on? Okay, I'm going to assume the slides are visible again. So just to say that there was a very acceptable angiographic, physiological, and intravascular imaging result on this vessel, and this was there's a lot of calcium identified on this using OCT, but of choosing the appropriate tools, choosing the appropriate stent sizes based on the intravascular imaging sizes. And I'm just going to move on to a second case now. Again, I'm not going to labor on this too long because I know we are running slightly behind schedule. This is an 84-year-old gentleman with hypertension, CKD with an EGFR of 35. He presented with an ACS in August this year. His ECG showed anterior T-wave inversion. We can see that there's severe diffuse calcific disease from the proximal to mid-LAD, which is considered the culprit vessel here due to the ECG changes. There's also severe diffuse calcified disease in the right coronary artery. On an initial heart team discussion whilst the patient was on table, it was considered that he was not a suitable candidate for surgical revascularization due to his age and also his CKD. So I proceeded to treat the LAD, acute LAD lesion with PCI, and was going to consider stage PCI to the right coronary artery. Initial pre-dilatation with a 2.5 millimeter semi-compliant balloon shows very poor expansion of the balloon, so there is a heavy burden of calcium here. So my next step was to undertake intravascular imaging here. So I proceeded again with Ultra and OCT. One difference you will see on this co-registered image here is that there is no contrast flowing down the vessel, and this is because I'm using saline as my flush medium here. So the Ultron software is calibrated for use with saline, and you can choose this as an option as you set up your run. Slightly more challenging to use saline here as a flush medium because it's lower viscosity than contrast. And you can see in the middle of the run, I do have a bit of dropout where there is some blood, but then I do manage to get all the information I need in terms of planning where I'm going to stent from and to. Again, if I just show a single still image here, axial image here, we can see that there's a 280-degree arc of calcium where there's the angigraphically most severe stenosis, and there's a 0.8 millimeter depth of calcium. So again, we're dealing with intimal and medial calcium here. Proximally, that's my vessel that I've set. I've set a 33 millimeter length. I've chosen my two landing zones, a proximal and a distal landing zone. We can see the lumen on the proximal area has a 3.15 millimeter diameter. Can't see enough EEL to be able to get an automatic detection of that. We can see on the 3-panel view here with my proximal and distal landing zones, again, I can see the lumen size is only not enough EEL to make a measurement, but we can do an EEL measurement ourselves. And so there I've seen two measurements, two orthogonal measurements of 4.0 millimeter diameter, 3.5 millimeter diameter. So we're looking at something a mean of about 3.75 millimeters for the proximal landing zone of this lesion. In terms of what I did next, I treated this segment with a 3 millimeter shockwave balloon using all 80 pulses, and this is based on the OCT measurements that I made. Tried further predilatation with a 3.0 millimeter non-compliant balloon and got uniform expansion, and treated with a 3.0 by 38 millimeter Zions. The midsection I postulated with a 3.5 millimeter non-compliant balloon, and the proximal segment with a 3.75 millimeter non-compliant balloon. This is now an OCT after stent deployment, and we can see the rendered stent in the longitudinal view at the bottom here. We can see that the stent expansion, the minimum stent expansion, is marked at 72% there. That's been slightly missensed because there is some blood swell. Again, I'm using saline because of this patient's CKD to flush the OCT, for the OCT run as a flush medium. So we don't get complete detection here, and we have an MSA measured at 3.3. The smallest MSA is 3.3. So based on OCT, this is a very acceptable result, and that was the end of that initial procedure. A few weeks later, the patient came back for treatment of their right coronary artery. You can see that there's severe calcified diffuse disease from the proximal segment down to the distal vessel. This is going back to one of my earlier comments that although we have so many different tools available to us with calcium modification nowadays, we need to realize that they're not mutually exclusive and they are actually complementary. I tried initially to predilate the vessel with a 2.0 millimeter balloon so that I could image it with OCT. But the OCT catheter was occlusive in the distal vessel, and therefore I was only able to image the mid and the proximal vessel for initial assessment. But that gave me adequate information to be able to decide what I was going to do in terms of treatment, but also to try and size the vessel as well. So I treated the mid vessel with rotational atherectomy, initially with a 1.25 millimeter burr and then a 1.75 millimeter burr. I was unable to get the 1.25 millimeter burr around the corner, and with the concern about stalling the burr in the distal right coronary artery, I decided not to pursue this too much. In this distal vessel, I was unable to pass a 2.5 millimeter shockwave balloon. I was unable to pass a 2.0 millimeter cutting balloon, but a non-compliant balloon passed down there. And this is often the unsung hero of calcified vessels. Multiple inflations in the same point with a non-compliant balloon can often modify the calcium, and this particular lesion here modified after about 6 serial inflations with a 2.5 millimeter non-compliant balloon. And to cut a long story short, went on to treat with 4 overlapping drug-eluting stents. There's 147 millimeters of stent now in this vessel, and at final OCT interrogation, there was greater than 85% stent expansion along the entire stent segment. So just to summarize, I think to be able to deliver optimized PCI in calcified vessels, we need to understand what the challenges of PCI in these vessels are. We need to understand when and how to use intracoronary imaging. We need to know that this has to be before, during, and after, and not just after we've deployed stents. A lot of procedures use OCT or IVUS after deploying stents, and these really become endorsed procedures rather than guided procedures. We need to understand what tools are available to us, that we can use them for complementary use and they're not mutually exclusive. We need to understand the difference between interval and medial calcification to choose our tools appropriately. We have to consider for high plaque burdens using ablative therapy. If you just use balloon-based therapy, you often end up with a small MSA because you can't push the material out any further. IVL has no doubt offered a paradigm shift in our treatment of calcified coronary arteries over the last 5 to 6 years. But the key thing is that there are no shortcuts in PCI of calcified coronary arteries. And if I was to summarize my one clear point for how to optimize treatment of coronary arteries with calcium, is to go through every single step, not to take any shortcuts, or you will have a suboptimal procedure. And certainly within my center, we are having the conversation at the moment that should treating calcified arteries be a generic interventional skill set, or should we be looking towards this as a procedural subspecialty? So if somebody does this on a weekly basis, should they be referred these cases? Much the same way as we think about that when we're talking about CTOs and things like that, should we be more cautious about everyone trying to undertake PCI in heavily calcified vessels? Thank you very much.
For the symposium, due to the time factor, actually we will not be able to entertain your questions, and we have to move into the next symposium without the tea break as well. So please be with us. Thank you so much.